Family caregivers are instrumental to the care of people with dementia in long-term care. However, as end of life nears, family caregivers are often left feeling stressed, overwhelmed, and uncertain of how to make the right decisions for their loved ones. My support study aims to support family caregivers and care home staff in the decision-making process in residential care homes for people with advanced dementia. The Comfort Care booklet, which provides information about dementia and comfort care at the end of life, is a core component of the My Support study.
Hi everyone, I'm Dr Marcel Arcand from Quebec, Canada. Today I wish to talk to you about the Comfort Care booklet, which I co-authored to help families understand the different challenges in the care of the patient near the end of life. It's to present the possibility of using a palliative care approach, which we usually thought was only for cancer patients, but it can also be applied in the context of advanced dementia. I worked in long-term care for many years and realized that most patients wouldn't want to live the Alzheimer's disease or any related disorders until the bitter end. Same thing with families. They face difficult decision and really they needed support. So that's why I wrote the booklet. There are some difficult decisions in the context of advanced dementia near the end of life. Most people will die from pneumonia or nutritional difficulties because of their difficulty swallowing. And the pneumonia is also because of the difficulty swallowing, because very often aspirate food in their lungs when they swallow. And this would eventually cause recurrent fevers, which we normally would treat with antibiotics. And with the Comfort Care option, I want to present other options. There is no universal moral stand. Now it's more about personal choice. So the question I ask myself when I'm facing an ethical challenge about treating with antibiotics or not, or using tube feeding or not, is the question is this appropriate for this patient at this time of his life? And I cannot answer that question alone. I have to discuss it with family representatives, and we hope we can make a consensus on what is the best approach. I read a chapter in a book called Controversies in Ethics in Long-Term Care, chapter written by Daniel Callahan, who people asked him to think about what should be done if a patient has advanced dementia, a complication like pneumonia or nutritional problems, and there is no family, and there is no advance directives. So when would it be okay to offer the palliative option or not to aim at prolonging life in this situation? And of course he said that we should be flexible. There are very different values and beliefs in different cultures and in different people, and we should be very flexible. However, he proposed 3 standards or rules of care which I found very useful in my practice. The first one is that no one should in the modern world have to live longer in the advanced stages of dementia than he or she would have in a pre-technological era, which means that we may have new technological means that could prolong life, but it doesn't mean we have to use them and make end of life more difficult in the 21st century than before. The second rule was the more advanced the damage of the dementia, the more legitimate it is to overturn the usual bias in favor of treatment, which means that maximization of comfort is more important at that stage rather than trying to prolong life. And this has been actually also proposed by the European Association for Palliative Care, who talks about goal shift as the disease progresses. The third standard or rule is whoever is making the decision has as strong an obligation to attempt to avoid a painful and degrading death as to promote a respect for the value of life. So as healthcare workers, we've got a double role at that period of the patient's life, which can be we can try to save life, making better, but also we have the role that to preserve dignity until the end. And I think sometimes we forget about that. We are sort of one-track mind towards applying medicine as the only role of medicine is to save lives. Later in my practice, I worked with a researcher to try to understand the decisional process of families when facing with the decision about treating or not with antibiotics, or using or not tube feeding, etc. And we realized that actually we interviewed many families and tried to sort out the factors which would influence more towards one option or the other. So we found out that for some people, well, mostly it's if the presence of advanced directives, written or oral, the patient would have manifested his desires. And actually in North America here, I think most people, a majority, maybe 80% of people, they really do not wish life to be prolonged if they can't decide anymore. But it's different in other cultures. There are also difference in the team perception of quality of life and the family perception of quality of life of the patient. It's very important to listen to families, what do they have to say. Sometimes you may think the patient doesn't have good quality of life. The family says, well, he reacts positively to my visit, he likes the food I bring, etc. So it's worth continuing to live. And I think we've got to be very careful to accept these family perceptions. Sometimes there are conflicts inside families, and we can understand that a person who feels guilty, for instance, of deciding that she can't keep the patient at home and he has to be admitted in long-term care, that the guilt feeling is there. And if we come up with discussions about using the comfort care option, not giving antibiotics, not using artificial nutrition, then this person cannot, at least alone, take this decision. So it would have to discuss with other members of the family, and sometimes there are differences. So that makes it difficult. At other times, there are absence of ties of the patient. I mean, the patient doesn't have a close family member that looks after him, and so we have to call a cousin or who's not in frequent relationship with the patient, and it may be easier for him to decide that yes, the comfort care option is the good option. So there are many factors like this. Also, what we realize during these interviews of family is that most families wouldn't know about the comfort care option if the healthcare team members don't present it to them. So they know palliative care for cancer, but they never thought that it could be applied to advanced dementia. So that's why I decided to write this booklet. You know, the ideal decision making would be shared decision making. I mean, family understand the palliative care option as well as the other options to prolong life, and the doctor and the team also understand there are both options are possible. And then they have positive and productive interactions to arrive at decisions that respect patients' wishes. And research has demonstrated that this increases family satisfaction with care making, and very often as well, comfort of the patient during the last days.